our last presentation for this afternoon relates to the COVID-19 pandemic and various improvements or lack thereof that are made in identifying patient outcomes. My colleague Thomas Valley is an assistant professor of pulmonary and critical care medicine at the University of Michigan. Dr. Valley would share with us some of his work on the MCURES study. Tom?
Thanks so much for having me here today. I'm very excited to be here, and I want to sincerely thank you all for participating in this meeting today. Really some wonderful questions that I've heard from the group, and for being a part of such a valuable piece of what we do every day at Michigan Medicine. My name is Tom Valley. I'm a physician. I work primarily in the intensive care unit, and my research focuses on how we can best deliver care to really sick patients in our hospital and in other hospitals. And I've been fortunate to be a part of two major studies that happened entirely as a result of the data that you have provided as participants and patients of Michigan Medicine. First, I was fortunate to be a part of the study that identified racial bias in pulse oximetry, the study that Rachel brought up in the beginning of this session. We identified that pulse oximeters are less accurate in Black patients than they are in white patients. And this study was a direct result of Michigan Medicine. We identified this problem first while caring for patients here at Michigan Medicine. And thanks to you, we had access to a large quantity of data that allowed us to look more deeply at this problem. And a result of what we saw here using data from patients hospitalized at Michigan Medicine, that motivated us to then confirm our findings using data from 178 hospitals around the country. And as a result of that work and a result of the data from Michigan Medicine, the FDA is looking into this. There's a meeting planned for later this year aimed specifically at trying to understand what happened and how to make sure pulse oximeters work as well for Black patients as they do for other patients. And so I wanted to thank you all for being the key to identifying and addressing this crucial problem. But today I'm really going to focus on a second project that I've been fortunate to be involved in and is directly related to our experiences from COVID-19. And I want to highlight the contributions of the MCURES team, really spearheaded by Karandeep Singh, Jenna Wines, and Mike Schoding. And again, I wanted to thank you all for your key participation in this work. One battle with Ohio that we really didn't want to win was this one. And that was early in the 2020 surge of COVID. We unfortunately destroyed that state down south when it came to COVID cases. I mean, we just had way more cases. And as much as we probably don't want to travel back in time, we're really going to need to for this talk to remember how chaotic a time it was, how frightening it was, how we didn't really know or understand what was going on related to COVID, how to best treat it, when to come into the hospital, when it was safe for patients to leave the hospital. There's so much that we didn't know. And, we might feel numb to some extent, feel numb about COVID now, but back then we certainly did not feel numb, right? We were scared. We didn't know what to do. And I think what's really remarkable to think about compared to where we are now to where we were at that time, how sick patients were with COVID were on average at that time, right? Now we do still have very sick patients with COVID, but back then, our hospital was filled with patients on ventilators who had COVID-19. And so there was a lot of really severe disease. And so now, these days, we're talking about a lot of patients, a lot of individuals who have COVID, right? But not that many who are hospitalized with COVID. Back then, we were really talking, because we didn't have good testing, we were really talking about like hospitalizations, COVID hospitalizations. And so back then, we had hundreds of patients just within Michigan Medicine hospitalized with COVID, and most of those patients were really, really sick, needing oxygen, needing to be on ventilators. And this red line that you can see here actually reflects the first time our study team, our MCURES study team met. So I looked back at my calendar and it was March 28th. And at that time, we recognized that this was going to be a big problem. We already had nearly 100 patients hospitalized with COVID at Michigan Medicine. The projection said that number was going to double, triple, perhaps even worse. And we recognized that we needed to do something, that this was a critical problem. And we wanted to know what we could do as clinicians, as researchers, to try to help patients who were admitted with COVID. And it helped us to recognize that we have great potential here at Michigan Medicine, thanks to the participants on this call, thanks to the individuals hospitalized at Michigan Medicine over the years. We have a wealth of data that we can leverage to improve care for our patients back in 2020, as well as for our patients today. And there were two key problems that we recognized very early during COVID. And the first, I think, is the most obvious, that there were super sick patients. There were some really, really sick patients. And we needed to be able to identify who is sickest and make sure that they receive the highest levels of care. But speaking as a physician, it's actually not that hard. It's not really difficult to look at a patient and say, oh boy, that patient's really sick. That's actually fairly easy when people are like super sick already, to say, okay, yeah, like this person's sick, we better get them to the intensive care unit. It's another thing altogether to be able to tell ahead of time who's going to be sick. So you might not look sick now, but what's going to happen 4 hours, 12 hours, 24 hours from now? Are you going to be sick then? And that's what we really needed during COVID, especially early in COVID, because this image here reflects some of the difficulty we had in caring for patients with COVID. You can see the personal protective equipment that clinicians had to wear. We can see that it's a closed room. We can see that we're trying to, even though there are 6 people at this bed, we're generally trying to minimize the number of people at the bedside. We have to recognize the importance of having kind of proactive discussions with patients and families about what to expect. And in general, especially during that early time, because we had so many patients that we were taking care of, we had fewer available healthcare staff, right? People were kind of stretched really thin. So you have less nurses and physicians taking care of these patients as we normally did. And so we needed more lead time, right? We needed to be able to have a little bit extra time to prepare for someone who might get really sick. And that differed compared to what life was like before COVID, right? This is kind of a usual occurrence before COVID, before 2020. It's hard for us to even remember what that was like, but this is kind of what it was like. You had large teams of staff taking care of sick patients alongside family in an open environment, and healthcare pre-COVID had increasingly been moving towards this open environment, open spaces, not closed off rooms, incorporating everybody at the bedside, making sure everybody's kind of up to date, knows what's going on. That was kind of the goal of care pre-COVID. And then all of a sudden COVID hits and everything gets flipped around, right? Now we can't have that many people at the bedside. Shoot, we weren't even allowing visitors in the hospital at that time. You have closed off rooms. So everything was exactly opposite of what we really wanted care to be like. And so as a result, when we had that first MCURES meeting, one of the most important questions we recognized that we needed to ask was a fairly obvious one. Can we better identify sick patients? Can we identify those folks who should go to the intensive care unit? And ideally, how early can we identify these people, right? Can we give some amount of lead time so that we can prepare ourselves, so that we can say, hey, 4 hours from now, this person might get really sick. Let's start preparing it. Let's start talking to the patient. Let's start talking to the family. Let's get the team ready so that we're prepared if this person gets sicker. The second, less obvious question also came up. And it actually came up pretty early during that 2020 surge in Michigan. And it relates to this figure again. We quickly realized that our hospital was going to run out of beds. I mean, how scary was that? I never thought in my lifetime we would see what we saw in early 2020, which was a situation where we, Michigan Medicine as a hospital at that time that was trying to relieve the strain of Detroit and was actively trying to bring some of those patients over so that we could offload those hospitals, we were getting to a point where we might have to turn people away, where our 800 beds would be entirely full of patients suffering with COVID. And that problem wasn't just an inflow problem. It wasn't just that we were getting inundated with patients with COVID. It was also an outflow problem. It was also that once we had these patients with COVID, they were really sick. And we kept getting these new patients, but we were having a lot of difficulty in trying to get these patients better so that they could get out of the hospital and get back home. And so before COVID, we used a model of discharge kind of like this one, where you got someone better from their illness, and then you wave bye as their family wheels them out of the hospital, and they're as close to where they were now as they were from before they got to the hospital. This wasn't always the case, but this was kind of the goal, right? The goal before COVID was to treat as much as you could within a hospital before sending someone home, because a home generally wasn't thought of as generally the best place for people who were sick to receive care. But COVID totally flipped that script, right? Now we had patients on oxygen for long periods of time. Generally, before COVID, we tried not to send people home on new oxygen unless they really seemed like they were going to need it for some period of time. Many patients just weren't at our historical standard of being ready for discharge. And it got so dreary that at certain points during the pandemic, early in the pandemic, we had so few patients who were actually getting discharged home that we were playing the victors on the overhead speakers anytime a single patient got discharged from the hospital. I mean, how crazy is that to look back on? We were so excited that a single patient was getting discharged from the hospital that we were having literal celebrations in the halls of the hospital, right? It's unheard of, but that's where we were at that time. It was really difficult to discharge patients from the hospital. And also, in fact, if you remember back to that time, our hospital was so full that we were actually preparing to turn the university's track and field house into a makeshift hospital. That's how bad things were, right? That's pretty darn bad when we're talking about turning a track and field stadium into a hospital, when we were talking about turning a dormitory into a hospital, right? These were dire straits. And so a second question that wasn't immediately obvious to us, but certainly became obvious to us very quickly, was that we needed to also better identify who's not sick, who could potentially receive care outside of the traditional hospital, but in a field hospital, who could be safely discharged out of the hospital. And so that's kind of where we were. We needed to not only better identify sick patients, but also better identify not sick patients, individuals who might be able to receive care elsewhere so that we could bring in some of those really sick folks. Before we started from scratch, the first thing we asked ourselves was, do we have anything that already can do that trick? Do we have already something that already can answer this question without having to start from scratch? And as you probably know from using the portal, we at Michigan Medicine use Epic as our electronic medical record, or MyChart. And Epic offers a proprietary system that seeks to predict whether a patient will get really sick during their hospitalization. It's called the deterioration index. So basically it's trying to predict who's going to get really sick. And here's kind of a hypothetical example that Epic offers of what this looks like, right? And we can see based on this image, this person has kind of a medium risk of getting super sick. And these are the factors that contribute to that score. And so this was available in Epic at that time. But what we wanted to know was like, how well does this actually work? Because Epic actually didn't really provide those data. Like, does this work really well or not? And in work led by Karandeep Singh, we incorporated data from our patients here at Michigan Medicine, from you. And we showed that the Epic model, it's okay, but it's actually not great for either of these questions to predict who gets sick but also to predict who doesn't get sick and who's not going to get sick and who could potentially go home. So it works okay, but we felt like we could do better. And fortunately, we had access to your data, to our data here at Michigan Medicine, to be able to try to answer those two questions. We felt motivated that we had an opportunity to improve care using the data that you've been able to provide for us. And so we did a couple things. So first, we used data from patients hospitalized at Michigan Medicine between 2015 and 2019 to predict what we call clinical deterioration. Basically, we wanted to predict who might get sick in the hospital and need treatments that might take someone to the intensive care unit. So our first step was to create an algorithm that could predict whether a patient would get sick in the future. Our second step was to then test how well we could predict that question, to predict, will a patient get sick, using Michigan Medicine data from later years, from COVID years, from 2020 to 2021. So we wanted to create this algorithm first, and then we wanted to use our data from later years to see, does it work? And now I'll be honest with you, what I've described so far in terms of creating an algorithm to predict whether something will happen to a patient, to be honest, as a researcher, even as a physician, it's not particularly interesting. Everyone does it, and usually nothing ever comes from it. But I want to get into some of the really key and interesting aspects of what we did. First, I want to highlight a number of Michigan Medicine patients whose data directly contributed to this study. So we used data from 25,306 patients hospitalized at Michigan Medicine from 2015 to 2021. So truly an immense quantity of data from individuals hospitalized at Michigan Medicine, which was key to these studies. But here's where things really start getting cool. So not only did we create an algorithm using our own data from Michigan Medicine, and then test how well this algorithm worked at Michigan Medicine, we also took an additional step that rarely, if ever, happens. What we did was we tested how well this algorithm that we made using your data, our data from Michigan Medicine, we tested how well it worked when applied to individuals admitted with COVID-19 to 12 hospitals around the country. So 12 hospitals that were both community hospitals and academic medical centers, both small as well as mid-sized and large hospitals in regions that were geographically distinct from us. So outside the Midwest, in the Northeast, the South, and the West. So from throughout the US, we tested how well this Michigan Medicine-based algorithm worked at these 12 different hospitals. So we took our own data from Michigan Medicine, created something new, and then we wanted to see how well it would work outside of Michigan Medicine. And here's what we found. At Michigan Medicine, this model, which we called MCURES, outperformed that proprietary EPIC model. So that EPIC model that that the EPIC electronic medical record created, our homegrown MCURES outperformed that. And that model, when we tested it across those 12 hospitals, it actually worked really well. And that's rarely been done before, where someone creates something at one place and then tests it really broadly across the country. And this model could identify both of what we wanted. We could identify those sick people, those people who are going to get sick, but it could also identify those folks who are in the hospital, but they're not going to get sick in the future, right? And so we really wanted to know both of those things. So what does this mean? Well, first, as you can imagine, it's so important that we as clinicians are able to identify who's going to be sick before it actually happens, right? It's almost like that movie Minority Report with Tom Cruise, right? The dream in medicine is to be able to say, hey, this person right here is going to be sick in 12 hours. What can we do right now to prevent that from happening, right? Like that's the dream in medicine. And this model, based on your data, actually gives us a chance of that. Second, we could identify 95% of the patients with COVID-19 who were at low risk of actually getting sick in the future, right? It's one thing to say like, hey, we got to keep an eye on this person, they might get sick. it's totally like the other side of the coin to be able to say like, hey, this person actually has a really low risk of getting sick over, the next 5 days. Maybe they might be able to go home, right? How nice would that be to not have to waste time in the hospital if we're not actually going to be doing anything differently than you could be able to do at home. And so these are folks who could potentially get discharged home, or in a really bad situation like we were in back in 2020, potentially get discharged to a field hospital. And this could potentially save up to 8 days in the hospital for each patient this algorithm was used on. And then finally, we did something that very few people ever do, which is we created something within one hospital, and then we saw if it might work in a bunch of other hospitals. And what we did could serve as a roadmap for future work just like this. Now, everything I've talked about so far focuses on the past, right? That's the problem here. Everything I've focused on talks about the past. And I think what we all on this call really care about is how is this going to change care in the future, right? How is this going to improve care for individuals hospitalized at Michigan Medicine and more broadly? And for that, I actually have some great news. Today at Michigan Medicine, we use the MCURES algorithm every day to try to predict which of our patients might get sick. Every day, our rapid response team, which goes around the hospital trying to prevent people from getting sick, or if they do get sick, help to make sure that they get the best, fastest care possible. Every day, this rapid response team uses the MCURES algorithm to decide which patients in the hospital, and the entire hospital, need the most care. So twice a day, they look at my chart, look at who has the highest MCURE score, and then they proactively go around and check on those patients. And so our goal moving forward is to make sure we integrate MCURES into everyday care to keep patients safe and healthy, both at Michigan Medicine and more broadly. So I'd like to conclude by acknowledging the many key members of the MCURES team, including this work that was led by Fahad Kamran and Chengpu Tang, as well as really spearheaded by Mike Schoeding and Jenna Wines. And most certainly, I want to thank you all for your participation within Precision Health and as patients of Michigan Medicine. So thank you all.
And thank you very much, Dr. Valley. This is very exciting. We do have a few minutes. I know you have to go in a few minutes for clinical duties. I want to reiterate one of the patient's comments of appreciation, thanking you for your service and indicating that it's set to remember, but it's even worse to forget some of the issues that pertain to obviously COVID-19. Now, one of the questions asked by Betsy asks, does the MCURE algorithm learn and improve based on medical HCP input and outcomes?
Yeah, Betsy, that's an awesome question. And that's something that we wrestle with, right? Like as we put an algorithm into place, care changes, right? Like all of a sudden we say like, oh, hey, these folks need extra attention. Now these folks get extra attention, these folks get less attention. And so there's a need to constantly iterate and improve and work on these algorithms. And so you're absolutely right. There's a need for that. Right now, we have one base algorithm, but over time, we are working with Precision Health, with the MCURES team, to be able to create models that can learn from themselves over time, adjust themselves, adjust the inputs, as you said, based on how we're providing care, so that they get tweaked over time and continue to be tailored to the patients that we're caring for.
Thank you. Any other questions or comments from the participants before we let Dr. Valley move on? He unfortunately will not be able to stay for the panel at the end, but we do have our 3 other presenters will be on the panel that starts in the next minute or so. I don't see any more questions, so thank you again very much, Dr. Valley. We now move on into our panel discussion. Here are the colleagues that are going to be helping us address some of the questions that were posed earlier or questions that people may want to bring now. First, Dr. Amy Pasternak, who presented on the genetics and medication response, remember early on. Then we had Dr. Amy Bonnard, who presented on the prompt mental health study. And last but certainly not least, Dr. Chad Brummett, who presented focusing on opioid misuse. So our three colleagues are here with us and ready to answer any questions that we did not have a chance to address already. So please go ahead and post your questions. I will start with a question posted by one of the participants. It asks about positron emission tomography, PET imaging, and whether it can potentially be employed as a treatment of chronic pain. Chad, would you like to take this question? I know it's an interesting one.
Yeah, I don't know how PET would be used as a treatment for chronic pain, and maybe I'm just not thinking about this the right way, so feel free to type more in the chat. But we've done some PET imaging studies, and I think the advantage of PET imaging, which is different, which is that we can actually go in, when we look at brains, we can see structure, we can see changes in blood flow, but the current brain imaging techniques don't allow you to actually know much about what's happening at a receptor level. And so an example of what a PET study that we just finished was for patients undergoing total knee replacement. They got radio labeled, meaning that it would light up if it bound to a part of the brain. Carfentanil, which is a fentanyl analog that is very potent, but given at super low doses, we just go in and bind. And it allowed us to see whether there were opioid receptors available in the brain, with the concept that if their receptors are available, then theoretically giving that person an opioid would be helpful as compared to a person for whom it might be less helpful. As a treatment, though, I'm not totally sure I know how that would be applied. I think it's an interesting, it's very interesting from a scientific perspective, understanding mechanism and biology. It's very complex, it's time consuming, and it's expensive. So these studies tend to be incredibly small. But yeah.
That's a good point. I'll just echo this and mention that PET imaging, as well as some of the other imaging techniques that we have, including magnetic resonance, CT, and so forth, they're used as detection processes to find out the brain structure, the brain physiology. Now, obviously, radiation can be used, including gamma knife, to address, to change brain anatomy, specifically in oncology, can be used in brain cancers. However, positron emission tomography itself is essentially a detection tool. Now, one of our colleagues, Alex Da Silva, is using it extensively, along with FNERS, to study pain, specifically in migraine. So PET imaging and SPECT imaging, for that matter, play a huge role when it comes to studying pain, but not for treatment of pain. So absolutely, Dr. Brummett is very much correct with this. Any other questions or comments anybody wants to bring to the panel on any of the topics that we discussed